Hello, I'm Dr. Wanda Torres, MD. I am the founder of Suncoast Women's Care, a medical facility renowned for our expertise in women's reproductive health, obstetrics, minimally invasive surgery, and robotic-assisted surgery. Join me each week as I interview guests in the top of their fields about the world of OBGYN, exploring the innovations and personal stories that shape our medical experiences. Hello, everyone. Welcome again to our podcast series, Conversations with Your Physicians and Nurse Midwife. Today we have Dr. Natalia Bukavin, and she's going to be talking about osteoporosis. Thank you, Dr. Bukavin, for joining us again.
Yeah, thank you for having me.
So, osteoporosis, let's delve a little bit into it. So, what is it?
Osteoporosis is a condition that happens when the rate at which we're breaking down our bone starts to happen faster than the rate at which we're building up our bone. And that can definitely have some serious effects on women's health.
So, what are the risk factors for osteoporosis? Do we need to be more aggressive in treatment with certain populations?
Yeah, so all women are at risk of osteoporosis, especially after menopause. But certain women, we do recommend screening a little earlier. So the normal time to start screening, the average recommended time is in postmenopausal women around the age of 65. But there are certain risk factors that make us want to screen a little sooner. So in women who either have a family history of osteoporosis or they have had any kind of fragility fracture, which I explain to patients when you broke a bone where you really weren't expecting to, like a fall from a short distance or something like that. Or women who smoke cigarettes, those women are at increased risk. Women who have heavy alcohol use definitely also increases risk. Certain medical conditions like hyperparathyroidism or rheumatoid arthritis, even inflammatory bowel disease can make women be at higher risk for osteoporosis.
For patients that are in a prolonged use of corticosteroids that can affect the bone density.
Absolutely, yeah.
So, what is the diagnostic test for osteopenia versus osteoporosis?
Good question, because those are different. Yes, osteopenia is like the precursor to osteoporosis. So we have normal bone density and then osteopenia and then osteoporosis. And our goal is always to prevent progression of osteopenia to osteoporosis when we do notice it. Osteopenia is when we see that the bone density is getting weaker, but it's not quite severe enough to meet the diagnosis of osteoporosis.
So the diagnostic test is the bone mineral density or the DEXA scan. So what is that?
Yeah, so that's a commonly asked question. Women are saying, what happens when you tell me to go get this test? And so I explain to them it's similar to an x-ray, and they look at different bones in the body. Commonly, they'll look at the spine, and they'll look at one of the long bones of the leg, the femur, and they'll measure several areas on those bones, and the machine has the ability to see how dense the bones are. We know, based on something called the T-score, that when the bone density is less than negative 2.5, that meets the criteria for osteoporosis.
Is there a way that I can prevent osteoporosis? How do I do that?
Yeah, so there are some lifestyle ways that women can incorporate into their schedules, their routines to help decrease the risk of developing osteoporosis or decrease the risk of progression. I always tell women if they're smoking, to work on cutting down on smoking. Alcohol every once in a while is fine, but heavy alcohol use is something that can really be changed in their lifestyle to help keep their bones healthy longer. And then exercise. Weight-bearing exercise is so important to keep those bones strong. I advise women to either incorporate some weightlifting into their exercise routine, or if they are into walking and that's something that's a part of their routine, adding some weight with a weighted vest can be really, really beneficial. Of course, dietary, calcium, vitamin D, both are super important for bone health. Vitamin D, the recommended daily intake is around 800 international units. A lot of supplements over the counter actually have more than that, but 800 is the minimum. And then calcium, 1,200 milligrams. But I do like to advise patients that that is a big dose of calcium to take through a supplement and sometimes can cause kidney stones in certain people. So I advise to look at dairy sources. If they're able to eat dairy, I say a glass of milk has about 300 milligrams of calcium, and then they can kind of use that to gauge how much they're getting from their diet and then supplementing the rest with a supplement.
Yes, sometimes I agree with that. Sometimes I just tell the patients food sources of calcium are wonderful. And if you are having a high intake of that, you can do 600 milligrams of the oral supplement plus your food source and your nutrition.
Yeah.
So then how do we treat osteoporosis?
I recommend lifestyle, diet, exercise in patients who either have normal bone density or who have osteopenia. And then we do screen those patients a little bit more closely to watch for development of osteoporosis. Once osteoporosis is diagnosed, really medication is the best way to keep people safe because the risk of untreated osteoporosis is fractures, and that can be really serious, especially as we age. There are several classes of medications that are used. I'll name some names just in case patients might have heard them. So one of class is called bisphosphonates. Um, an example of that is Boniva. That is a medication. All of these work to help decrease the rate of breakdown of bone and kind of reverse or try and stop that progression of bone loss. There's also a class of medication called monoclonal antibodies. Prolia is an example if you've heard of that one before. And similarly, it helps to decrease the rate of bone loss. That is administered as an injection. And then there's also different medications that help to work on our estrogen receptors to help also our bones stop breaking down and remain strong. And an example of that would be something like raloxifene.
Well, great. Thank you for all that information. Now, the diagnostic test, of course, is the bone density. How frequently should we be doing that, and at what age should we start?
Yeah, absolutely. So, postmenopausal women, no risk factors. The recommendation is to start at age 65. After that, as long as bone density screening is normal, the recommendation is to continue approximately every 5 years. Now, if at any point there is a reason to increase screening, if there's a fragility fracture or there's a new discovered family diagnosis, that can change. If people are diagnosed with osteopenia, the recommendation is to screen every 2 years and then, of course, implement those changes that we talked about to help stop progression. In women who have risk factors for osteoporosis, like the ones we previously discussed, the recommendation is to start screening when they have reached menopause.
So, abnormal pap smear
Yeah.
is a consultation that we get a lot in the office. So, tell us about the pap smear and what are we trying to detect?
So pap smears is a screening test used to detect any abnormal changes in the cervix, and also it has the ability to test for the presence of the HPV virus.
So, this HPV virus, how does a patient acquire it? And I know there's different types. There's the low risk and the high risk. Can you tell us a little bit about this?
Yes. So it's actually I tell my patients, and I think they're surprised to hear this because I was surprised to learn this too, how common HPV is. So HPV is a virus. It is a sexually transmitted infection that, you're right, has different strains. And certain strains cause things like genital warts. And then there's different strains, specifically among others, strains 16 and 18. And those are really associated with cervical cancer in women. Now, HPV can cause problems for men. It can sometimes cause penile cancer. It can certainly cause genital warts. But a lot of the strains that are really cause a lot of problems for women, the men can be symptomatic. And so I really think it's important to educate patients that their partners might not be aware of their carrier status of HPV. And so, unknowingly, they might be transmitting this virus that could have really serious implications for women. And, I learned that approximately like 75-80% of people will be infected with HPV virus at some point in their life, which is shocking. Yeah.
It is very shocking, but is there a way that we can counsel our patients that we can prevent this transmission of HPV?
Yes, there is. So, and the best way is the pap smear. Well, for screening, but for prevention, because HPV and cervical cancer, it's the as far as I know, the only cancer that can be prevented with a vaccine, and that's incredible,
Isn't
right?
that wonderful?
Yes, and so there is an HPV vaccine. It is recommended. So the ideal time to receive it is really before any kind of exposure to HPV has occurred. So girls and boys, um, around for girls around age 9 to 11 is when the vaccine is recommended. And an early age, it's given as a series of 2 vaccines. But just because you didn't receive it when you were 9 or 11 does not mean that you can't get it now because it has been approved up to age 46. And so women who haven't received it as children, who've been maybe sexually active in the past, potentially have been exposed, they can still get the vaccine. It's just a series of 3 injections. So 1 injection, and then 2 months later a second, and then 6 months later they get the 3rd vaccine to complete the series.
So a very common referral to our office is the abnormal pap smear, and sometimes we get the ASCUS pap, sometimes we get the low grade SIL pap, and sometimes we get the high grade SIL. So what do we do to further diagnose this?
Yeah. So really, with those results, it really depends on the patient's age, their health, their kind of coexisting conditions. Are they immunosuppressed? Their history of prior pap smears leading up to this abnormal pap that we see. But commonly, if there is an abnormality, especially if we see that high risk HPV, the way to really determine or follow up the pap smear is to do something called colposcopy. And that involves, I tell patients, it involves looking at your cervix with a big camera that and putting special stains on the cervix that lets us really see those abnormal cells. And then the biopsy is really what's really important because that helps us determine, is there something that is concerning for any kind of precancerous or cancerous changes?
Okay. So let's say, Dr. Bukavin, that we do have a patient that after doing the colposcopy, we received a biopsy and is showing CIN2 or 3, which it used to be called severe dysplasia.
Mhm.
So how do we manage that patient?
Yeah. So patients like that oftentimes would need an excisional procedure to remove the abnormal cells. And that can be done in one of 2 ways. One way is to do something called a cold knife cone, which is done usually in the operating room. The kind of the transformation zone or the area right around the cervix is removed in a circular fashion. It really does resemble a cone when it's removed, and the hope is that you remove all of those cells that have been negatively affected by the HPV virus and by the dysplasia, the changes. The second way is very similar in the fact that a circular portion of the cervix is removed, but it's called it's done with an electrical loop. Okay, so it's called a LEAP procedure. Um, both are similar,
Mhm.
but the benefit of the LEAP procedure is it can be associated with less bleeding. It's also a procedure that can be done in the office under local anesthesia, light sedation, or with the use of an anxiolytic um,
And with the nitrous oxide.
and with the nitrous oxide, yes, which is so wonderful.
It is wonderful. Now, to educate our patients, how often should I be getting a pap smear?
Mm-hmm.
Because it depends on age group, right?
Depends on the age group. Yeah. So starting age 21, really important that all women, especially sexually active women, start getting their annual or their pap smears. They used to be annual, but that's not the recommendation anymore.
Mhm.
So the recommendation is to do a pap smear every 3 years for women between ages 21 and 30. And in those women, we don't automatically screen for HPV,
Mhm.
right? And the reason for that, why I tell patients, and the reason is because HPV, like we mentioned, is a virus.
Mhm.
So it's even if a woman is infected with it, a woman with a healthy immune system, she's pretty likely to clear the virus. And so we really want to see, have there been any changes related to the virus in the cervix? If there is an abnormality on the pap smear, oftentimes it'll reflex to the HPV test. So then we can see if there has been an infection. But the recommendation is to do cytology only until age 30 every 3 years.
Uh, I'm glad you mentioned that it used to be that we recommended the pap smears every year.
Mm-hmm.
And now, there's new guidelines and recommendations, but we still like to see our patients every year at the office because we have to review history, review medications, review how their menstrual cycles are, if they need contraception. So that's why, ladies, we like to see you every year in our
Mhm.
office. But going back to the pap smear, so you mentioned between 21 and 30. So how about past the age of 30? What do we need to do?
So, depending on the screening that's done, screening after age 30 can take place in a range between 3 and 5 years.
Mm.
And we're talking about normal results here, right? If women have a normal history of results. So, women can do a cytology and they can do HPV. It's called co testing, and that can be done every 5 years. They can do HPV only testing every 3 years. At our practice, we like to be really, really thorough. And so we do co testing every 3 years for women. Um,
Mhm.
I think it's a nice middle ground that helps our patients feel safe and then, helps us be sure that we're catching any abnormalities as they arrive.
Agreed. And how about the menopausal patient after
Mhm.
the age of 65 or someone that has had a hysterectomy?
Mhm.
How do we manage those patients?
Yeah, so I'll start with the hysterectomy. So again, it depends on what was our pap smear result leading up to the hysterectomy, right? If we've had a normal result, then when we don't have a hysterectomy, as long as it's a not a super cervical hysterectomy, right? We have to know, do
That's
we
right.
have a cervix, right?
That's right.
If we have a cervix, we have to do pap smears,
Yes.
right? And women under 65, which we'll get to over 65. But if they don't have a cervix, they've had a normal pap smears, then we can forget about the pap smear, and that's not really something that women have to worry about
Mhm.
anymore. If there have been abnormalities, then screening is oftentimes recommended, especially if it's a severe abnormality. Then doing a pap smear, even in the absence of a cervix, doing just a pap of the vaginal cuff of the top of the vagina is recommended. And the screening interval depends, and again, on the abnormality. But usually, you want to continue at least 20 years after the last abnormal
Mhm.
result.
Correct. So I always like to guide my patients that are past the age of 65 because if they don't need a pap smear anymore, why visit the GYN?
Mm-hmm.
Well, in my opinion, those patients need to continue seeing us because they could have issues with vaginal cancers or
Mm-hmm.
vulvar cancers,
Mm-hmm.
vulvar lesions. So we need to continue seeing
Mm-hmm.
those patients. But how about the pap smear after the age of 65?
Yeah, so the recommendation is that after 65, if there have been normal pap smears for 20 years or no history of abnormalities, the recommendation is that we can discontinue pap smears. I like to tell my patients that your cervix did not read the book and, say I'm over 65, so nothing bad can happen, right? So I still advise them to exactly that. At the office visit, I'll always look at the cervix. If I see anything abnormal, of course, that's a reason to screen. Even in a patient, if they have a new sexual partner
Mhm.
and potentially have a new exposure to the HPV virus, then that would be a reason to screen. Or in any cases of postmenopausal bleeding, I think ruling out any kind of cervical abnormality is also very important. So yes, over 65, if we have a long history of normal pap smears, it's okay to discontinue routine screening, but then very, very important to still come in, still get checked out, still have an exam to make sure that everything remains healthy.
So now, talking a little bit about obstetrics, because I know that you like GYN, but you have been delivering quite a few of our babies, and that has been a very good experience, and the patients are loving you for that. So tell me a little bit about that.
Oh yes. I mean, I remember this obstetrics is why I fell in love with OBGYN. I remember I was in my third year of medical school and I really wanted to go into OBGYN. And so I stayed late to when the residents were away. And it was just me and one of the attending doctors. And um, we were called to a delivery and the baby was delivering. I thought I'd just be standing there, just as medical students do. They just stand and observe. And then he said, okay, here, go ahead, deliver the baby. And, it was somehow with his help, of course, and guidance and support, we delivered the baby safely. And then I went and I was so overwhelmed. I cried. And I feel like that was it, right? So I feel like being in the room, supporting a woman, supporting her husband, her family through meeting their baby is such a privilege. And just to get to be there,
Mhm.
and witness all the love in that room and, help to guide them and help to keep them safe, of course.
Mhm.
I think that that is a huge privilege. And I remind myself of that every time.
Well, fantastic. Anything else that you would like to add so that the patients get to know you?
Yeah. Just want to say I'm super, super happy to be here. I hope that, everybody feels open and willing to come to me if they have any questions. I tell patients, no question is too stupid. Nothing is too gross for gynecology, okay? There's nothing that's too embarrassing. I love the idea of women helping women, which is why I thought Suncoast was really fit well with my ideals for the profession and what I wanted to do. And so I just hope that we can work together to keep all the women in our practice as healthy as possible for the rest of their lives.
Agreed. Well, thank you very much for all that fabulous information, and thanks for joining us in this podcast, Dr.
Thank
Bukavet.
you.